I'd like to invite Dr. Charuta. I think Charuta, you'll be next. She'll be speaking about progressive endothelial cell loss in keratoconus post-CXL, endemic, epidemic, or neither of the above. Again, a very, very important issue, I think, and something we need to be careful about. So how many in the hall are uh, routinely doing cross-linking? I mean, we have a few people. Because, cross-linking is something which is uh, done not only by the cornea specialists, it's done by the ocular of comprehensive ophthalmologists as well. And it's important to know the nuances of that. So,
Very good morning, everyone, and I'm very happy to be here in Vizag, and thank you for the opportunity. Dr. Chintan, very nice to see you after a long time. I'm excited to be part of this session on corneal ectasia to present this very important case that we have been following up for the last 1.5 years. So, this is a 22-year-old male patient hailing from South India. He presented to me in 2016 with a history of having undergone cross-linking in another institute in 2013 in the left eye and 2015 in the right eye. So he had right eye haziness in the. I'm sorry. Can I get the pointer? I'm not able to use the mouse on this. Yeah. Thank you. Thank you. Just can you give me a mouse, please? Mouse, only mouse. Thank you. Bus. So he presented to us with complaints of right eye persistent haziness in vision since the procedure, and we could not contact the surgeon. So to ask him whether it was an eventful or an uneventful procedure, and but the institute where the surgery has been performed was known to follow a strict Dresden protocol for all cross-linking cases. So on examination, his visual acuity was 6/36 in the right eye, and it was improving to 6/6 parts with correction. And he was reluctant for a contact lens trial because he said the very reason why I underwent, an extra procedure was because I didn't want to use any either glasses or contact lenses. Now he had these persistent epithelial erosions along with it. I don't have a fluorescein stain image, but and a very low Schirmer score, that is 8 millimeters at 5 minutes. So in the for this we prescribed topical PEG PPG substitutes, and over the next 3 months the erosions actually resolved. And after 1 year of observation and non-resolution of that scar, we performed a simple limbal epithelial transplant, which we know reduces the scar density. So we explained to him that the scar density would reduce over time, and then post-procedure over the next 9 months, as you can see, the scar density has reduced, and he was now 6/18 unaided. This was the initial presentation. As you can see, even in the anti-segment OCT, we can see that there is reduction in the reflectivity, and also there was some increase in the pachymetry. So post-procedure, the pachymetry actually increased, and you can see that there is no significant difference in the epithelial thickness map. But the patient 6/18 was obviously still not happy, and he continued to have experienced blurring of vision for the distance. Now we amply explained to him that there is nothing else that we can do right now. And in January 2021, he presented with again persistent complaints. So at this visit, I just noticed that there was some endothelial involvement of the scar area, as you can see in with the red arrow mark. And specular microscopy showed poor cell density in the right eye, that is 1702 as compared to the left eye, which was 2370. So he was suggested to use ripasudil eye drops based on anecdotal results from the Japanese group, and he used it on an off-label basis with an adequate consent form for 4 months. Subsequently, after 4 months of usage and 2 months of discontinuation of the rock inhibitor, the symptoms slightly worsened and then improved very significantly, and then the specular imaging at the next visit also showed an improved count. So here you can see that the counts have improved. However, if you see the hexagonality, the coefficient of variation, all parameters have not really improved that well. But the patient was asymptomatic as compared as a result with regards to his haze symptoms. So this is the summary of the case. That is in 2013 and 15 the cross-linking was done. SLET was done in 2017. Endothelial involvement was noted almost 6 years after, 8 years after the cross-linking. And then on Reposudil, the count slightly improved and the symptoms improved. So coming to what might have caused it, so we know that UV irradiation is known to be potentially cytotoxic and pro-apoptotic in mammalian cells. So the initial works that were done by Wolensack have in fact done the animal studies for this purpose itself. So what it does is it causes the formation of singlet oxygen, superoxide and hydrogen peroxide species in the endothelial cell, not in the upper layers, and these consequently can result in apoptosis of the endothelial cells. Now UVA has been reported to be cytotoxic in porcine keratocytes at a level of 4 milliwatts per centimeter square. But when it is combined with riboflavin, the irradiation induces cell damage at an even lower level, that is 0.35 milliwatts per centimeter square. So this may be explained by the photosensitizing effect of riboflavin. And riboflavin, when it is imbibed into the corneal stroma, has been demonstrated to enhance the absorption coefficient. Therefore, the UV light is sort of limited as long as you have a thickness of greater than 400 microns from the endothelium is shielded. Now, insufficient instillation of riboflavin or an incomplete removal of the incomplete epithelial abrasion will limit the riboflavin inhibition, and therefore it increases the UV irradiation. So we have to understand that epithelium has to be off for better absorption of the riboflavin, especially in isotonic cases. And UV irradiance and cytotoxicity at the endothelial level increases in such cases. And to avoid this, cross-linking inclusion criteria have been suggested and to be strictly followed as 400 microns minimum thickness. Other things that can go wrong are the calibration errors, incorrect focusing of light, which can happen because of patient movement, tilt in the head level, or a thin stroma with epithelial hypertrophy, which may mask the true thickness. Now, to avoid the UV light overdosing, it is utmost importance to adhere to these safety parameters, and which vary according to the device that we are using. So it's best, especially now in the area where a lot of companies are offering devices from one hospital to the other. It's important to understand that every device has its own parameters and every device needs to be calibrated, especially if it's being moved from one place to another. Now, in order to minimize endothelial toxicity, also the hypotonic use of hypotonic riboflavin was also suggested, and epithelial mapping is also very important in these cases, as we'll see. This is a slide that Dr. Nikhil Gokhale has lent to me, and this is one of the cases which very beautifully demonstrates how the epithelial hypertrophy can mask actual stromal thickness. So we are looking at a 400 micron stromal thickness and not the epithelial masked thickness. So before doing a C3R, the message that this diagram is trying to tell us is that before doing a hypotonic C3R, based on the pentacam, you need to go back and look at the individual images where the thinnest point is there and see what is the stromal thickness exactly. So if you go to all maps in your global pachymetry map, you will be able to see individual maps and then have a look at whether there is any epithelial masking happening or not. So in Keratoconus, so in an in-house study in Medivision Hospital, so this data was kindly shared by Dr. Rupak Reddy from Medivision Hospital, wherein one of their DNB students actually followed up for the period of 6 months, short-term changes in endothelial cell density after doing collagen cross-linking. So 35 patients specular microscopy was done at 3 time points, that is before the cross-linking, after the cross-linking at 3 months and at 6 months. And interestingly, at 14.29% at 3 months showed a 200 to 400 density reduction, and 22% almost showed a 200 to 400 cell density reduction at 6 months, and 8% of the cases showed a progressive cell loss. Ma'am, can I take just 2 minutes more? It's almost the last slide. So far we found that in literature nobody has actually demonstrated, actually described long-term endothelial cell loss, and this is what we are doing. So what we feel as a conclusion is that LASIK extra or PRK extra procedures may have pushed the limits of time-tested protocols. But extending indications of cross-linking to a normal cornea is not free from its risks, and I think there may be more cases that are coming up. We are currently following up another case, also similar case, unfortunately done at the same hospital, but she has also presented to us 6 years later, and we started her on ripasudil, and unfortunately there was no change absolutely in the cell count. However, she was having very similar symptoms to Fuchs dystrophy, wherein she was getting morning haziness, which has resolved after starting ripasudil.
So thank you, Dr. Charuta. I think what you've highlighted, the effect of the cross-linking on the endothelium is something, again, we need to look at carefully, whether it be in the extra procedures where we are doing it as a refractive procedure, or it be in keratoconus, especially in keratoconus where we have thinner corneas.
What I think is it's at least justified for doing it in keratoconus. If you're subjecting a normal patient to the risk, another extra risk.
Yeah, I think although I myself am personally not a fan of extra procedures, but there are a lot of people doing it, and we need to wait for long-term literature, to say completely that whether we can completely put that aside and debunk that or not. But so what are your thoughts on, there's another school of thought these days that says that the endothelium is actually much more resistant to UV light than it was thought earlier. Especially I'm talking about cross-linking, and people are going in for higher energies to do cross-link, especially in transepithelial cross-linking.
Yeah,
so
I mean,
any views on
at
that?
This point of time, to resort to human beings as an experimental model is actually not justified when we have so many animal models.
No, that's been done in animal models, and then it's been shown to be safe in transepithelial at least. But definitely one has to be very careful, and then looking at the endothelial cell counts, that should be mandatory as a preoperative workup for before you're doing any cross-linking, and serial follow-ups, and also specular clinical examination or specular reflection, so that you look at whether there are any pre-existing endothelial abnormalities is there.
So if I may add to that point, actually, so there was one case of there were two cases which were shared by Dr. Fogla, wherein he felt that the stroma was looking absolutely acellular. That is, the cross-linking is actually killing the stromal keratocytes, whatever are left also, which is actually defeating the purpose. And in this conference itself, Dr. Pankaj, if he is still here, has shared a few cases of CTK. That is the toxic keratolysis, wherein the again similar probably phenomena happening. So I know you're asking about endothelial toxicity per se, but I'm sure that you're not really safe.
Of course, that's the mechanism how cross-linking works, right? We all know that it does. In addition to cross-linking, it does cause keratocyte apoptosis, at least above the demarcation line. And it's ultimately later on that the keratocytes are repopulating the cornea. So that is to be expected in the initial phases. Up to the depth
I mean,
of
he was selling a couple of years after.
Sorry?
Dr. Fogla's case was 7 years or 8 years post.
Yeah, so and there's not been too many long-term studies on how quickly the keratocytes repopulated. And that's why, because apoptosis is a known mechanism, but I think endothelial toxicities. And the other thing, one thing I wanted to point out, sometimes this is, in the acute cases, once you're doing cross-linking, sometimes cross-linking can also lead to reactivation of HSV, and that can cause HSV endotheliitis. And that can be a cause of corneal edema sometimes, which we may think is due to excessive energy. So that again needs to be looked at.